and welcome everybody to our webinar. We are about to get started to tell you about a novel syndrome that is associated with prenatal fentanyl exposure. And this is going to be a really interesting presentation, I hope. I'm looking forward to talking to you about this. Today, we'll have 3 speakers. The first speaker will be Erin Wadman, a genetic counselor who will talk to us about the patients and their physical findings. Then we will have Carolina Alves, a senior AI researcher from FDNA, who will tell us how she successfully used the Gestalt Matcher algorithm from the Phase2 Gene tool to objectively quantify differences and similarities in facial features in our patients. And then I will take it from there and talk to you about the evidence that we have for a possible novel syndrome. So I'm really looking forward to going through this with you. And I want to draw your attention to our recent publication on this novel syndrome associated with prenatal fentanyl exposure. This publication is available to everybody in Genetics in Medicine Open. Genetics in Medicine Open is the new journal from ACMG. And as the title implies, anybody can look at these articles. So please take a look at this article and also pay attention to the supplemental material, because a lot of the information is actually in the supplemental material, because there's only so much we can put in the original manuscript text. So a lot of the things we will touch upon briefly today. If you have any additional need to review that, please look at the entire manuscript and the supplemental materials. So it's now time to get started, and we will get started by having Erin Wadman, a genetic counselor who works with me at the Nemours Children's Hospital in Wilmington, Delaware, take it by telling you about the patients and their findings. So Erin, please take it from here.
Thank you, Dr. Gripp. Go ahead and get this started. All right. So this story begins with a patient A who Dr. Gripp and I first saw in August of 2022. And he was referred and evaluated at 10 weeks of age due to a history of talipes equinovarus, sacral dimple, developmental dysplasia of the hip, hearing concerns, and narrow shoulder girdle, as well as a left eye cross. The pregnancy history was reported by the foster mom who came to the appointment, and it was remarkable for maternal chronic hepatitis, cellulitis, and exposures including fentanyl, amphetamines, and methadone. There was overall limited prenatal care. He was born at 36 weeks, 5 days, and he was overall small at birth, with his birth weight being about 2.4 kilograms, birth length 45 centimeters, birth head circumference 31.5 centimeters. At birth, the maternal and infant urine drug screen was positive for fentanyl, and he had a NICU stay for 6 weeks due to neonatal abstinence syndrome. On physical exam, it was notable for hypotonia, microcephaly, and micrognathia. He was notably very cute, but he had distinctive facial features, including full cheeks, short nasal tip and prominent columella, well-formed and long philtrum, thin upper lip, unilateral talipes equinovarus, bilateral single palmar creases, mildly broad adducted thumbs, hooded foreskin and penile torsion, as well as unilateral 2-3 toe syndactyly. He failed his newborn hearing screen, and there was moderate hearing loss, likely secondary to some recurrent ear infections he was having. He was also noted to have cortical visual impairment, but he had a normal brain MRI. And at the time of the visit, we recommended that he have a 7 and 8 dehydrocholesterol level obtained due to the 2-3 toe syndactyly and other features possibly consistent with a condition called Smith-Lemli-Opitz. These levels were normal at 10 weeks of age. As is typical for someone with multiple congenital anomalies, a SNP array was performed and it identified normal male chromosome complement. Later, a proband-only exome was performed, and it showed a heterozygous VUS in a gene DCHS1. Pathogenic variants in this gene are associated with an autosomal recessive skeletal dysplasia condition, so we did not feel that this was consistent with our patient's phenotype. And during the appointment with patient A, his distinctive facial features, multiple congenital anomalies, and prenatal exposures reminded me of another patient I had seen a few months earlier in 2022. And this patient is patient B, who was initially seen as an inpatient genetics consult at Nemours at 4 weeks of age for a history of absent septum pellucidum, bilateral retinal coloboma, cleft palate, neonatal abstinence syndrome, and ongoing feeding concerns requiring NG tube. His pregnancy history was also remarkable for polysubstance use, including cigarettes, alcohol, and fentanyl, although the alcohol levels were not reported to be at high levels. He was born at 37 weeks. He was overall small at birth as well, his birth weight being about 3 kilograms, his birth length 46 centimeters, birth head circumference 30 centimeters. He was also transferred to the NICU for neonatal abstinence syndrome and discharged on day of life 28. At birth, the maternal and infant urine drug screen were also positive for fentanyl. On physical exam, he was noted to have hypotonia, microcephaly, small stature, ptosis, epicanthal folds, anteverted nares, full cheeks, low set overfolded helices, micrognathia, long flat philtrum, cleft palate, as well as cortical thumb position, bilateral single palmar creases, bilateral 2-3 toe syndactyly, and bilateral talipes equinovarus. And you can probably appreciate from the photos on the right the striking resemblance to patient A. So during his inpatient stay, there were concerns for a possible genetic etiology, such as Smith-Lemli-Opitz syndrome. During the stay, a microarray was performed and it showed a likely benign VUS. A 7 and 8 dehydrocholesterol level was also sent, and this was mildly elevated at 1 month of age, although there wasn't subsequent draws that were performed. A proband-only exome was also performed, which showed a hemizygous VUS in the gene DCX. Pathogenic variants are associated with X-linked lissencephaly and subcortical band heterotopia in this gene, and his brain MRI was not consistent with this, so we did not feel that this was diagnostic for him. And I saw this patient along with Dr. Erica Fernandez in the multidisciplinary cleft and craniofacial clinic at Nemours in July of 2022. So after remembering patient B, I was also then reminded of other patients that Dr. Fernandez and I, who we had seen through the cleft and craniofacial clinic at Nemours. And these are patients B, C, D, E, and F on the right. And these patients all had cleft palate, none had cleft lip, and also had micrognathia. They all share fairly similar, distinct facial features, all had single palmar creases, mildly broad adducted thumbs, 2-3 toe syndactyly, the talipes equinovarus, or some had rocker bottom feet. There were genitourinary anomalies. For those that had a brain MRI performed, some had hypoplastic corpus callosum, and all had feeding difficulties requiring G-tube feeds. Patients C and D were also initially suspected to have Smith-Lemli-Opitz syndrome. Postnatally, they elevated 7 and 8 dehydrocholesterol levels were noted, but these were later normalized on subsequent draws. Patient C also had normal DHCR7 sequencing and deletion duplication analysis that I'll go into more detail on. all had extensive non-diagnostic genetic workup, including a microarray and exome. All had some prenatal exposures, although fentanyl was the only one common to all, and the fentanyl was reportedly used at high levels and continuously through the pregnancy in these patients here. Of those tested at birth, all had positive maternal and infant urine drug screen for fentanyl. So at this point, it might be helpful to talk about what is Smith-Lemli-Opitz syndrome. It is an autosomal recessive genetic condition that is caused by abnormal cholesterol metabolism due to deficiency of 7-dehydrocholesterol reductase. It is characterized by pre and postnatal microcephaly, moderate to severe intellectual disability, and multiple congenital anomalies that can include distinctive facial features. So you can appreciate those from the photos on the right of patients who have Smith-Lemli-Opitz syndrome. They can have cleft palate, cardiac defects, underdeveloped external genitalia in males, postaxial polydactyly, and 2-3 toe syndactyly. They have elevated serum concentration of 7-dehydrocholesterol. In some cases, there may be low serum concentration of cholesterol. And then on genetic testing, you can identify biallelic pathogenic variants in DHCR7. So thinking back to our group of patients, all of whom had non-diagnostic genetic testing, we had to ask ourselves, did we stumble across something novel, or are we just reinventing the wheel? So we first, from the cohort of patients, we received IRB approval for the study and enrolled max 6 cases at Nemours Children's Health in Delaware. Our patients did share a phenotypic overlap with those with Smith-Lemli-Opitz syndrome. They share similar distinctive facial features, as well as the multiple congenital anomalies listed, like the cleft palate, talipes equinovarus, the GU anomalies, microcephaly, 2-3 toe syndactyly, single palmar crease. They overall were small. There was feeding difficulties, and our patients also had some neurodevelopmental differences. Elevated 7 and 8 dehydrocholesterol was normalized for those patients who had subsequent draws in our cohort. That is not typically seen with people who have Smith-Lemli-Opitz. You would expect that those would remain elevated. And our patients also had non-diagnostic genetic testing, even in some cases specifically for the gene associated with Smith-Lemli-Opitz, and all had non-diagnostic exome as well. And we also had to ask ourselves, is this just fetal alcohol syndrome? Our patients shared some similar distinctive facial features, but not as similar that we thought with Smith-Lemli-Opitz. There was some maternal alcohol use during our pregnancies. However, there was more multi-system involvement seen in our cohort of patients with prenatal fentanyl exposure who also had abnormal metabolic levels that are not typically seen with FAS. So the question remained, is this a distinct and novel syndrome associated with prenatal fentanyl exposure? So now I have the pleasure of introducing Carolina. Carolina is a senior AI researcher at FDA with experience in biomedical research and data science. She is passionate about leveraging data to improve patients' lives and is currently working on developing solutions to shorten the time to diagnosis in children. Carolina lives in Coimbra, Portugal.
Thank you, Erin, for the introduction. So I would like to start my presentation with talking a little bit about deep gestalt, because this is the technological basis of the analysis that we did. So deep gestalt is a deep convolutional neural network that has been trained using thousands of photos of children that are affected by different genetic disorders. When we are presented with a new input photo, first we do some pre-processing. First we detect the face. We also detect the facial landmarks that you see here in green. we align the face first, and then we crop it into different regions. You can see here, for example, the eye area, the mouth area, and more. Then each of these regions pass through the layers of the neural network. And as you can see here, with each new layer, we are basically extracting the most relevant features from the face that represent the facial phenotype of that child. Then, in the end, we aggregate this information from these different regions, and we get a vector with the top 30 most likely syndromes that the child might have, which are basically the most similar to the facial phenotype of that child. Now, if we look at the final layer before the syndrome classification output in DeepGestalt, we actually have this vector of 320 values, basically this vector of numbers, that is a numerical representation of the facial phenotype. Now, if we condense these high-dimensional vectors into just two values, 2 dimensions, we are then able to represent each face in a 2D scatter plot like you see here, where each data point represents a patient's photo. Now, the smaller the distances between these data points, the more similar their facial phenotypic features are. You can see here, for example, that patients that have been diagnosed with the same syndrome, for example, here coffin series, tend to cluster together in this space. Now, the name of this technology is Gestalt Matcher, and we can leverage these facial phenotype descriptors, these like data points, these vectors, for syndrome classification, delineating new phenotypes, and also clustering patients. And this was exactly the technology that we use for the analysis for the publication that we are discussing here today. So we took the photos from the selected patients that Erin just presented, and we also took age, gender, and ethnicity matched photos of our target comparison groups. These are the unaffected controls, here in blue, represented in blue, Smith-Lemli-Opitz in orange, and fetal alcohol syndrome in green. These two are potential confounder syndromes, as Erin previously covered. We then converted each photo from these groups into their facial phenotype descriptor, basically the data points that we are seeing here in this plot. And you can also see these ellipses that are represented here. And they are actually one standard deviation around the cluster center. So you can think of them as the cluster core for each of these groups. And we can already see, just from looking at this visualization, that there is already some separation between the potential novel syndrome here in red and the other groups. If, for example, we represent these same high-dimensional vectors, but now in 3 dimensions, meaning that we are basically condensing a little bit less the information, right? We are able to visualize a little bit more data here. We can see that the red crosses here that represent a novel syndrome still separate even maybe a little bit more clear than what we saw in the previous 2D plot from the other comparison groups that we are analyzing. Now, the question that we wanted to answer is if the novel syndrome is more similar to itself than to the target matched groups. To answer it, we first compare the novel syndrome to itself with what we call an intragroup similarity analysis. What this means is we take, for example, this data point from the potential novel syndrome, and we calculated the cosine similarity with basically every other point within the novel syndrome. Then we repeated this process for the second data point, calculating the similarities that were not previously covered, and so on with the remaining data points. So this is the intragroup similarity, where we are comparing the novel syndrome to itself. Then we also wanted to compare the novel syndrome to the other groups with intergroup similarity. So we did the same cosine similarity comparison, but now we are comparing all the data points from the novel syndrome with all the data points from each of the other groups. For example, here between the novel syndrome and the unaffected group, here with the Smith-Lemli-Opitz group in orange, and also the fetal alcohol syndrome group. Here you can see the similarity distribution between the novel syndrome versus itself, and then the novel syndrome versus the other groups that we have now discussed. If you are not familiar with this box plot visualization, you can think of it as this top-down view of the distribution. We have the minimum and maximum values, we have the median value here in the middle, and the first and third quartile. So in this visualization, we can already see that there is at least a tendency for the similarity of the new syndrome compared to itself being higher than the new syndrome compared to the other groups. But then we wanted to conduct some statistical tests to be sure that this was really happening in a significant way. So prior to that group comparison, we made sure that we could apply parametric testing. So the samples that you see here are independent, they have normal distributions, equal variance, and also no outliers. So then we conducted a one-way ANOVA to compare the 4 groups. This test compares the means between the groups and determines whether any of those means are significantly different from the others. As you can see, our results had a p-value that is well below 0.05, meaning there is a high statistically significant difference between these 4 groups. But however, the ANOVA does not really tell us between which pairs of groups this difference occurs. So we needed to follow it with independent t-tests between the new syndrome and the other groups. So that's exactly what we did. And based on these results, we can say that the novel syndrome intragroup similarity was indeed significantly different, and as we saw before in the other plot, higher than the similarity with the other groups. So these findings suggest that the novel syndrome has a facial phenotype associated with it that is cohesive and separates well from the phenotypes of the other syndromes and also the unaffected groups. So if you are interested in conducting this type of research, and analysis using Gestalt Matcher or Deep Gestalt, as I introduced before, feel free to contact us at research@fdna.com, and we'd be very happy to support you with your research project. So now I'm very glad to introduce Dr. Karen Gripp. She is the Chief of the Division of Medical Genetics at the Nemours Children's Hospital in Wilmington, Delaware. And her research interests include rasopathies, craniofacial disorders, novel syndrome delineation, and identification of disease genes. Dr. Gripp serves also as FDNA's Chief Medical Officer.
Thank you, Carolina, for this really elegant work. This is great. So I will now take it from here, and we will review what evidence we have for this possible novel syndrome based on the work that Erin and Carolina already presented to you. So this image here is a composite of the photos of the 6 patients that Erin had described to you in detail. This is a composite of the 6 images that Carolina worked with in her analysis. And when you look at this, I think you can easily appreciate the distinctive facial features with a little bit of ptosis, the really low nasal bridge, a very short nasal tip, micrognathia, and a thin upper lip that then results in a really long philtrum. So there are characteristic and distinctive facial features as Carolina described. So we now have these 6 individuals that share facial features that are distinctive from Smith-Lemli-Opitz and fetal alcohol syndrome. And these 6 patients also share physical features that are somewhat similar and suggestive of Smith-Lemli-Opitz syndrome. In fact, they also had slightly elevated 7 and 8 dihydrocholesterol when the testing was done in real early infancy, but this resolved subsequently. So for all of these patients, we performed genetic testing that was non-diagnostic, but we also noted that each of them had significant prenatal exposure to fentanyl. We were able to present these 6 patients as a poster at the ACMG meeting earlier this year, and very quickly, colleagues from other institutions were able to share 4 cases that they had seen that were very similar to the patients we already talked about. So we very quickly added 4 very similar cases from outside institutions. So now we have a total of 10 cases. The first 6 are from our institution. Cases 5 and 6 are the result of a twin pregnancy, but they are of opposite sex. For the 10 patients, all had a short nasal tip, many had a thin upper lip, and interestingly, a cleft palate was seen in 7 of 10. Micrognathia, as well as a single palmar crease, was noted in all. The short, slightly broad, and adducted thumb was present in 9. Foot position abnormalities were common with talipes equinovarus in 3 and rocker bottom feet in 3. The 2-3 syndactyly was present in 8 of 10. Genital anomalies affected males. In those who had a brain MRI, a diffusely thin or hypoplastic corpus callosum was noted in 5 of 9. We already mentioned the abnormal dihydrocholesterol values that normalized subsequently, and all 10 had non-diagnostic genetic testing. So now when we review the evidence on these 10 individuals, again, we have findings that are somewhat suggestive of Smith-Lemli-Opitz syndrome, but the metabolic findings resolved and the genetic testing was non-diagnostic. However, all 10 patients had significant prenatal exposure with fentanyl due to maternal opioid use disorder. So at this point, our hypothesis was that large doses of fentanyl used throughout the pregnancy could act as a teratogen, and that this mechanism could possibly be by interfering with cholesterol metabolism. So when we review what we know about prenatal opioid exposure, it is well known that opioid use in pregnancy is associated with preterm delivery and with infants who are small for gestational age, have a small head circumference, and who have neonatal abstinence syndrome. There are many studies looking at congenital anomalies after opioid exposure in pregnancy, and overall, the results are quite variable. But a systematic review of the evidence found a possible association with oral clefts, congenital heart disease, and talipes equinovarus. We know that fentanyl is very effectively transferred to the fetus in early pregnancy, and this would certainly be absolutely necessary in order for fentanyl to be able to cause birth defects. Animal models of opioid exposure during pregnancy are known to result in pups that have decreased birth weight and brain mass, but it's also important to recognize that typically the opioids that are used in these studies are not fentanyl. It is also well known that there are many drugs, in particular psychotropic drugs, that can affect cholesterol metabolism. And this is important work that was published by Dr. Corrade et al. While there are drug libraries that are available for screening to see if drugs have an effect on cells or on cholesterol metabolism, for example, or on other metabolic pathways, it is important to note that these drug libraries do not contain fentanyl. So while a lot of work has been done, there is really not much known about fentanyl or how fentanyl affects cholesterol metabolism. So now we turn to criteria that can be used when one wants to assess if a new drug or a new environmental exposure could possibly result in birth defects. So we assess the evidence for teratogenicity in humans. And we look at criteria that were proposed by Dr. Hill in 1965. Those are the Bradford-Hill criteria. And then we will also look at the Shepard criteria proposed in 1994 in order to study this concept of proving human teratogenicity. The last time these criteria were used was by Dr. Sonja Rasmussen, who applied these criteria to birth defects, in particular microcephaly and brain abnormalities after Zika virus infection in pregnancy. So we will now apply these criteria to our novel syndrome associated with fetal fentanyl exposure, and we will model that very closely following Dr. Rasmussen's very important work. So when we look at the Bradford-Hill criteria, one criterion is the strength of the association. And it's clear that our cases were very quickly identified. So I think this is a strong association, even though the number is small. So I would say, yes, this criterion could be met. Consistency of the cases, it is very clear that the cases from the outside institution are very similar and support the consistency of the phenotype. So yes to that. Specificity, when we look at the characteristic physical findings in combination with the early abnormal biochemical findings in the absence of a diagnosis of Smith-Lemli-Opitz syndrome, and we look at the characteristic facial features, I think it's fair to say that, yes, this is a specific novel syndrome. In regards to the temporality, the fentanyl use epidemic in the last few years would allow a novel syndrome to be identified now. So I think yes to temporality. In regards to the biologic gradient, specific dosage measurements, documentation, and knowing when exactly how much of the drug was consumed throughout pregnancy, we clearly do not have this information. So you can imagine, due to the circumstances, that is really not available to us. So no, we do not have a biologic gradient at this time. In regards to plausibility, we know that fentanyl is effectively transferred across the placenta in early gestation. And we also know that the fentanyl transfer is not affected by the simultaneous presence of other drugs, for example, heroin. And we do know that other opioids can be associated with an increased risk for congenital anomalies. So I think yes to this plausibility criterion. In regards to coherence, the congenital anomalies resemble Smith-Lemli-Opitz syndrome, and we seem to see that there was abnormal cholesterol metabolism throughout the pregnancy, even noted in the early neonatal period. So I would say yes to that. It is very clear that we currently do not have animal models recapitulating this novel syndrome, so no to the experimental evidence. And I find the analogy in particular interesting because with alcohol use disorder, you know that that can result in children with fetal alcohol syndrome or fetal alcohol spectrum disorder. And I think this is a very similar condition in the sense that some, but not all children born after a pregnancy with exposure can have these findings. So I would say, yes, we have an analogous condition to point to. So for the Bradford-Hill criteria, there is no threshold how many criteria have to be met for it to be considered meaningful. Rather, he suggested that each criterion is looked at independently. And so we've done that now. And you see that we've met many, but not all criteria. So now let's move on to the Shepard criteria. The first criterion here is the proven exposure to an agent during one or more critical times throughout prenatal development. And in our cases, the exposure was throughout pregnancy. So yes to that. Criterion 2 consists of 2 or more high-quality epidemiologic studies. And it's very clear we do not currently have that, so no to that. Criterion number 3 is a careful delineation of the clinical cases and a specific defect or syndrome. And we've done that. This is a very distinctive syndrome, so yes to that. Criteria number 4 is rare environmental exposure that is associated with a rare defect. Thankfully, opioid use disorder in pregnancy is overall not common, although somewhat increasing recently. And the syndrome that resembles Smith-Lemli-Opitz syndrome with distinctive facial features is also uncommon. So overall, to see this together, I think we can say, yes, this is met. In regards to teratogenicity in experimental animals, this is a criterion that's considered important but not essential, and we do not meet that currently. The association should make biological sense. We've gone over that fentanyl is effectively transferred across the placenta and that other opioids are associated with birth defects. So I would say, yes, this does make biologic sense. And then lastly, prove in an experimental system that the agent acts in an unaltered state. And we know that fentanyl itself is the active substance. So yes to that. So for the Shepard criteria, either the first 3 criteria are considered essential and the others are supportive. And when we look at that, no, we do not meet these essential criteria. However, alternatively, criteria 1, 3, and 4 can be considered essential and the others are supportive criteria. So here you could say, yes, we do meet the essential criteria and some of the supportive criteria. So overall, when we look at these criteria, we can say, even with our small number of patients, the results are not inconsistent with a fetal fentanyl syndrome. However, we also cannot rule out that there is another substance or contaminant that's causal to this novel phenotype. Confirmation through independent studies is obviously necessary. And it would be great to have prospective studies documenting the amount of fetal fentanyl use and to show the outcome, possibly even showing a dose response gradient or a critical period for the exposure. Obviously, laboratory studies are needed, for example, to demonstrate fentanyl's effect on cholesterol metabolism. And we would need animal models that are exposed to high doses of fentanyl throughout pregnancy to possibly recapitulate some of the findings that we report in our patients here. So what are our next steps? We will ask about prenatal fentanyl exposure in infants with a suggestive phenotype, and we suggest that you do the same. And we plan on publishing additional cases. In fact, we expect to find a spectrum disorder where not every patient is as strikingly affected as the patients we talked about today. And we would also ask you that if you identify similar cases, please do publish them so that we can know that indeed this is an appropriate report to make. And if you have patients and you don't want to independently publish them, please contact us to share the cases. Clearly, larger cohort studies are needed, and we are hoping that the CDC will pick this up and follow through on that. And we also need to demonstrate fentanyl's effect on cholesterol metabolism. I already mentioned the work from Dr. Zelka Corrado that has been very helpful in us reviewing the information for the publication. And Dr. Corrado has kindly agreed to continue the work on this. She is looking for samples, in particularly from very young neonates, in order to get more information about the abnormalities of the cholesterol metabolism. And you can contact her here. She works with Dr. Carol Murnix at the Monroe-Meyer Institute for Genetics and Rehabilitation in Nebraska. And thankfully, this group will also continue to perform additional experiments, hopefully including animal experience with prenatal fentanyl exposure.